Mark. I appreciate it. It is hard to get through foot and ankle, maybe anything this time of day, but we're the foot's the part that holds the rest of this course up, supports it. We have a fellow this year, wonderful young man, Bobby Erden from little old tiny town in North Carolina. And when he heard I was coming to do this, he says, "Dr. Richardson, don't you teach them a thing. They've been taught for 5 years and they're tired of it. You just tell them which button to push." So what I did was we took 269 questions from 5 years of OITEs, and part of that, 200 questions of that, from self-assessment examinations over a 5-year period, 2 separate examinations. And then I took them and tried to condense them to themes and recurrent questions. So like Dr. McPherson said, there's, believe it or not compared to total joints, but in foot and ankle, there's a world of information out there in the last 10 years plus for sure that we could have added to this course. But what we want to do is just to have you end up the day you get your scores back and you say, well, I did okay in foot and ankle. That's what Dr. Miller wants you to do, and of course that's what I want you to do. And I told Dr. Miller, my son took this exam last year, the board exam, and he said, "Remember this, Pops, if they open that scorebook and they did all right on foot and ankle, they'll never remember your name. But if they didn't do well, they'll never forget it." That's from your own son. You know, it makes you feel good about yourself. I'll stop off and on and look down at my notes a little bit because I've added a few little things that just came to me later that I don't want you to miss. So hold on, we'll get through this together. If you look down at the foot and ankle section, about 6 or 7% of the questions will be on that. And I sure don't want you to miss any gimmies. So I'm going to try my best not to let you do that. If everything I say, that's not quite true, but you go on and think everything I say has been in a question phrased in some way or another, because that's where all this talk comes from. Stance phase of gait, 65% or so. Swing phase, 35%. That's roughly. Right here at heel strike, the heel is in varus, foot flat from here over to mid-stance phase. The mid-tarsal joints unlock. The tarsal-metatarsal joints unlock. At end of terminal stance phase toward this area and then toe off, the mid-tarsal joints are locked for stability. And remember this, at toe off, 0.8% of body weight is focused at the first metatarsal phalangeal joint. But if you let a lady get in a 2-inch heel, because that 0.8 is barefoot, it goes to 1.6 times body weight. So double the body weight, a 2-inch heel, terminal stance phase, toe-off gait. They don't ask too much about pure joint motion. You need to know that there's more inversion than eversion, more adduction than abduction, but they do ask combinations of motion. I think if you'll just lock in your mind that pronation, and I'm going to show you a slide that demonstrates that when we get over to the posterior tibial tendon insufficiency, dorsiflexion of the ankle, eversion of subtalar joint, abduction, transverse tarsal joint, and if you get that in your mind, you know that supination is the opposite, so you don't have to memorize both of them. They like to ask this. The TA contracts eccentrically at heel strike, gastroc quiet. Gastroc contracts concentrically at heel rise and push off, eccentrically at foot flat. They like that for some reason. Now, the windlass mechanism in some form or fashion is going to be on there, and they're going to bring in, of course, the plantar fascia into that mechanism. The origin and insertion of the plantar fascia, and it is, listen to me, a major support of the medial longitudinal arch, but it's not the major support. The major support is the capsulo-ligamentous, particularly plantar, structures that support the mid-tarsal and intercuneiform joints, particularly in the medial and central columns. But what they want to know is that what they're asking you here is the windlass mechanism is very important, so don't tamper with the plantar fascia unless you've got a good reason. It's the second most important support. The third is the dynamic support of the posterior tibial muscle. And finally, the last is joint congruity and alignment. That's the least support for the medial longitudinal arch, and for obvious reasons. Now, they like this one. They particularly like layer 2 and 3, and they like to get you on where the neurovascular bundles traverse, between which two intrinsic muscle layers do the neurovascular bundles traverse. So get that in your mind before the test. Now, the sural nerve, most vulnerable with that big extensile lateral approach for the calcaneus that the Seattle boys love. Lateral calcaneal branch is most likely to be injured if you're doing a calcaneal sliding osteotomy, for posterior tib insufficiency and you're trying to get rid of some of that heel valgus. It's the century to the dorsal fourth web space, and what I didn't put in there is 70 to 80% of the time. It's not categorically the sensation to the dorsal first web. And it's particularly vulnerable when you're repairing the Achilles tendon in the proximal part of your wound up near the musculotendinous junction. Sural nerve particularly vulnerable, and particularly vulnerable with the percutaneous technique. They like that one too. Dr. Miller will probably hit on that in the sports medicine section. I'm trying to read and think too up here. Now, the deep perineal nerve, that nerve that it dives beneath the medial edge of the EDB and EHB on its way across to the sinus tarsi. It's vulnerable with removing of the CN bar, innervates those muscles, compressed beneath the inferior retinaculum in anterior tarsal tunnel syndrome. I'm going to get to that a little bit later. It's injured during approach for reduction of Lisfranc injury. That might be on there too. Superficial perineal nerve, the dorsal medial aspect of the hallux. When you're doing a bunion, you got to protect that one. I don't know how many times I've cut it, but it's been a whole bunch. Lateral cutaneous, but you don't want to cut it on the exam. Lateral cutaneous branch most vulnerable with arthroscopic anterolateral porter and during ORF of the distal fibular fracture, particularly a Weber C. They like to throw that in there. You got to know the boundaries of your portals, like anterolateral, fibular lateral, and peroneus tertius medial. Just know your portals and make sure you don't go through that central portal. They don't like that one because that's you can damage some things you don't want to damage. The nerve, the superficial perineal nerve, emerges from the deep fascia 12 to 15 centimeters proximal to the tip of the lateral malleolus, can be stretched during an ankle sprain. They'll give you an ankle sprain patient. They just won't get well. Neuritis, neuralgia. Well, it's a traction injury at the superficial perineal nerve. Might even get RSD. The lateral plantar nerve is the motor nerve to the adductor hallucis, is a branch of the lateral plantar nerve. What I think you ought to do here is only memorize what the medial plantar nerve innervates. The abductor hallucis, the FHB, flexor digitorum brevis, and lumbricals 1 and 2 are to the second and third toes. They're not going to mess you up the fact that the second lumbrical is durally innervated, not infrequently. They'll just tell you that those three muscles plus 2 of the lumbricals, 1 or 2 of the lumbricals. Then the others are all lateral plantar nerve. You need to know this about the abductor hallucis. The proximal third of the muscle is where the innervation is. It's why you can be fairly cavalier mobilizing that muscle to get where you want to go with compartment syndromes or to release the distal part of a tarsal tunnel release. You can be, you can go at it pretty hard because there are 2 branches and they're all in the proximal third. You must be partially mobilized for adequate distal tarsal tunnel release. The deep fascia partially released, incised to release Baxter's nerve, which is the first branch of the lateral plantar nerve. those are the things below that, the decompressed deep plantar space, etc. Just get those in your mind as to why you want to mobilize it. Those are the reasons. Now, the FHL tendon and muscle, it's most vulnerable. You know this. You've heard it since your second year of your residency. Posterior medial corner subtalar joint during a subtalar fusion, or they'll say triple on the exam. Closest to the distal Achilles tendon. Now, this has been in the last 5 years. Can be harvested as a vascularized substitute transfer for chronic severe insertional Achilles tendonitis. They use words like this FHL lies below, deep, or dorsal to the FDL tendon at Henry's knot. Anterior tibial muscle tendon unit. Not sure why they asked this in the foot and ankle section, but they very well might. Originates from Gerdy's tubercle, innervated by the deep peroneal nerve. Now, what they are likely to come up with is a sudden onset of ankle dorsiflexion weakness in an active elderly patient. They rupture the tendon at its insertion. And another thing you need to know about it is mononeuralgia diabetica with a drop foot. Spontaneous onset of a drop foot in a diabetic, probably an ischemic event. The posterior tibial muscle tendon unit, I'll show you a little bit later, but they love to ask. It inserts on every bone in the mid-tarsus and metatarsus except the first metatarsal. I'll repeat a little bit of this as we get to those sections just for emphasis. The transverse metatarsal ligament holds the helical sesamoids in place as the first metatarsal head moves medially. This is a false image of subluxation. Your sesamoids are not subluxing, it's the head. It's the structure on which an interdigital neuroma is compressed when elevated heel shoes are worn. All of these are questions. The deltoid ligament, anterior tibio-talar portion, I wish I'd made that red. Most commonly injured medial structure in recurrent sprains. Most commonly injured medial structure, anteromedial tibio-talar portion. The deep deltoid is a primary restraint to talar subluxation in a lateral direction once the fibula is incompetent. The ATFL, primary ligamentous restraint to anterior subluxation tibio-talar joint. But what they probably are going to throw at you, and by the way, it's like Dr. McPherson said, this test will throw a few fastballs right down the center, maybe even a changeup, but they're not going to throw sliders or those curves that hit the outside of the corner. They're going to be pretty straight on you. What they're going to do is ask you for sagittal drawer force with the ankle and 20 degrees of plantar flexion. That's how you test the competency of the ATFL, plantar flexion. And Bassett's ligament, I don't know why they keep hammering this. Every time I read it, I get mad. But anomalous slip of the inferior tibiofibular ligament. It should not contribute to recurrent ankle sprain unless the ATFL is incompetent. Remember now, I said tibiofibular. That's a slip or a component of your distal syndesmosis anteriorly. The CFL, primary ligamentous restraint to inversion. Now, you test that with the ankle dorsiflexed. The spring ligament, they love the spring ligament, y'all. The origin, coronary cavity of the calcaneus, which really means the distal edge of the sustentaculum tali. Inferior distal edge of the sustentaculum. It inserts on the plantar inferior surface of the tarsal navicular. It's the most commonly injured component in posterior tibial tendon insufficiency. The most commonly part injured is the superomedial portion. Superomedial portion of the spring ligament is what gives way in posterior tibial insufficiency. It supports the talar head. Remember that the plantar aponeurosis sort of acts somewhere in between static and dynamic support because it inserts into the proximal phalanges and the flexor tendon sheaths of all 5 toes. Now the plantar plate, I'll tell you, they like to hit that too. It has to have the second MTP joint, and I'll get to that more because it deserves it. It must become lax before the abnormal dorsal translation of the proximal phalanx can occur. If you've got a positive Lachman at an MTP joint, excuse me, Dr. Miller, we use Lachmans too, the plantar plate has to be weak. Once attenuated, listen now, once the plantar plate's attenuated and the base of the proximal phalanx starts non-camming, starts sliding up, translating up, then the most deforming force to keep it going to the hammer toe, claw toe deformity is the EDL. It's weakest at its origin from the metatarsal neck. They like that one too. Now, the injury to the lateral medial plantar nerves and intrinsic minus hallux or intrinsic minus toes in the forefoot. Injury to the deep perineal nerve, weak or absent EDB and EHB functions, CMT and trauma. Another thing they'll ask you is check the posterior tibial muscle strength with the foot everted. Start off with it everted and plantar flexed to negate recruitment of the anterior tib with inversion. In other words, they can get it over to the midline, but they can't get it to past the midline if their posterior tibial tendon is out unless they recruit the TA and they start dorsiflexion and inverting. You've all seen it in the office in patients, in the clinic. You know what I'm talking about. Inability to initiate heel rise from stent phase, injury, posterior tibial tendon, inversion of dorsiflex ankle. Just gave you that and that, but that's for emphasis. Now, why do I throw a slide like that in? Because you're going to hear distal soft tissue realignment in a variety of bunion operations. Distal soft tissue realignment. Well, I want you to know what they're talking about. Bobby Urden said, don't tell them concepts, Dr. Richardson, tell them content. But I got to give you a little bit of concepts here. If these sesamoids are not in their facets, then you're going to get who cares about the sesamoids? What you care about is the muscles that go into them. And if the FHB and the adductor and the abductor hallucis are not balanced, you're going to get a recurrence of deformity. So, what they're talking about with distal soft tissue realignment is putting these sesamoids in their facets, therefore through the pulley system bringing the FHL back in place and realigning both the medial and lateral restraints and governing musculotendinous units. So that's why I emphasize that. This is just a visual that we dissected out, and I want you to look at it. One of the fellows a number of years ago did this dissection, Mike Simpson. But you see that little bitty bone here, that lateral sesamoid, and you see the tibial sesamoid. Well, you can see that these muscles converge on a little small area. And you also got to remember that the adductor hallucis doesn't just go to the base of the proximal phalanx. It is integrally involved and inserted on the lateral sesamoid and must be released. The FHL goes wherever these sesamoids take it. So anyway, that's enough for concepts. We'll get back just to content. I hate for you to have to sit down and memorize these angles, y'all, but you're going to have to do it. They're not that hard to remember, but you got to remember that the normal hallux valgus angle, less than 15. This metatarsus primus varus angle, it just means a cuneiform, medial cuneiform base of the first metatarsal angle, less than 25 degrees. That's the least important angle to remember, because if it looks like the first metatarsal is way over in varus, it is. And they're trying to tell you it's a hypermobile first ray, whatever that is. That's what they're trying to tell you on the exam. The first and second intermetatarsal angle, less than 10 degrees. Now, this one right here, you got to know. The DMAA, the distal metatarsal articular angle, less than 15 degrees. A normal resting posture of the hallux on the head of the first metatarsal is about 10 to 15 degrees. That's the way we were put together. That's the way we're supposed to be. But if that, look up here, if that scoop of ice cream falls off the cone in a little bit of valgus more than it should, then that's normal for that patient. You can't bring the toe straight and leave that crooked. And that's going to be the theme of some of the reason-driven operations that's ahead of us in a minute. Another visual, just for you to get an idea. Look over here. This is a little old 17-year-old girl who had adolescent or juvenile hallux valgus. Of course, she had to be a, a urologist's daughter, and of course her toe had to go crooked again. The distal metatarsal articular angle. This is the way you measure it. It's in the literature. You can measure it, but it's just to let you know this is a K-wire right here, and this is right down the center. Believe it or not, there's another K-wire over here hidden by this little Homan. But if this is excessive valgus posturing, you've got to plan it into your operation. And that's what they're trying to get you to learn and to do. They like words like mild, moderate, severe. So sort of implant that in your mind. And these angles, roughly, implant those in your mind. Less than 25 or less, HVA and an IMA of less than 12. A severe is 41 to 50 hallux valgus angle, intermetatarsal angle 16 to 20, and of course the moderates have got to be in between. They like to put this wording, severe hallux valgus, 48-year-old or 55-year-old person with severe hypomobile first ray. What they're asking you is to do a Lapidus. And what they're asking you in the one that's essentially in a wheelchair, and she's 87 years old and has to be woken up to eat her dinner, that's the one they want you to do a Keller in. I ain't laughing at her. I'm not far from there. The treatment options for the hallux valgus, you need to know some of the... I don't know why they keep throwing the Mitchell in there. I'm not going to tell you that I think the Mitchell is not that bad an operation. I think it is. You don't want to know that. But nonetheless, nobody does them anymore unless you're from Henry Ford Hospital. So, but it's still a good operation. But don't pick it. Never pick it on this exam. Now, a chevron osteotomy for mild, that's mild, isn't it? And it's congruent. I'm going to show you a picture of it in a minute. For incongruent joint, distal soft tissue realignment and a chevron. Either one of those are fine, or combined. Oh, the avascular necrosis of the capital fragment of a distal metatarsal osteotomy is not high like it was when Dr. Miller and I came along. He probably never paid much attention to that, but when I was coming along in this line of work, the avascular necrosis rate was very high, supposedly after a distal metatarsal chevron osteotomy. But that's out now. It's not. So you can do a web space release. So we'll get to that in just a minute. And I think this is the, seemed like I wrote down, yeah, page 315, table 5.4. If you'll write that down, just go to your text chapter, page 315, table 5.4. And that'll pretty much tell you what you need to know. Now, I don't believe you're going to be, I think this is a slider to throw y'all the shaft osteotomy. Have any of you heard of a long diaphyseal shaft osteotomy called a Ludloff or a scarf or a Mao? Any of you ever heard of that? See, I bet you they don't even ask you. It's about time for them to start asking about diaphyseal osteotomies. It's just about that time. So I'm going to tell you, all you have to remember are 2 or 3 things. Technically difficult operation. 2, troughing. T-R-O-U-G-H-I-N-G. All that means is when you make that big old cut up and down the bone and slide one fragment laterally to correct the intermetatarsal angle, one of the cortex, the medial cortex of the dorsal fragment, falls into the trough, the intramedullary canal of the plantar fragment. It rotates the bone, and you get a malunion and transfer metatarsalgia. Difficult operation, troughing, malunion with transfer metatarsalgia. I hope they don't ask you, but if somebody calls me and says, "Why didn't you talk about it?" at least I'll say I said something about it. I just know all those folks, and I bet it's about time for them to start doing it. Now, if you've got an adolescent hallux valgus with, see that congress joint? You see it might be a millimeter sublux, but essentially that's congress incongruity. They're asking you to do a biplanar distal chevron osteotomy. Biplanar, by that I mean translational and angular. You shove it over, 3 to 5 millimeters laterally, but you also do a 1 to 3 millimeter closing wedge osteotomy immediately to correct the DMAA. Can you see that if I brought that hallux completely straight with my medial capsulorrhaphy, wouldn't it be incongruous and varus? Does that make sense to y'all? Yeah. Now, in this patient, 62-year-old, HVA large, IMA large, severe, they're asking you for a proximal metatarsal osteotomy. They'll call it a crescentic or a chevron, but nonetheless, a proximal metatarsal osteotomy and that distal soft tissue realignment, trying to get these sesamoids back in their facets where they belong. Why? To reduce the rate of recurrence. So these are some exceptions or semi-outliers. Severe deformity in the elderly, a Keller resection, don't do the Mayo. You got an elderly patient with marked hallux valgus. The skin is tenuous medially. They keep breaking down even in a house shoe. That's the only place I can see that they're bringing you toward a simple bunionectomy, because you don't do it for any other reason. Hallux valgus and DJD, arthrodesis, except in the elderly sedentary patient, again, Keller. Hallux valgus in a Down syndrome patient with ligamentous laxity, a cerebral palsy patient, or the generalized Ehlers-Danlos without an underlying neurological problem. Arthrodesis, first MTP joint is what they want. Juvenile hallux valgus, usually with excessive DMA. They want a biplanar osteotomy. And the most common complication is recurrence of deformity. Now, do y'all see this big soft tissue swelling out here? And can you barely see a lytic area through here? If you see a lot of soft tissue swelling and they give you some acute onset of pain in this hallux valgus that wasn't bothering them too much before, they're probably pointing you toward gout, and they're probably pointing you toward an arthrodesis. I just didn't have an arthrodesis to show you, so she got a Keller. But they're probably pointing you toward, to breed this, you're not going to have much head left. You might need to bone graft it and fuse it. The most common cause of failure in hallux valgus surgery is insufficient preoperative assessment. Now, if there's a broad general statement like failure of hallux valgus surgery, that's the answer. If they're asking you why a specific procedure failed, a Keller, a proximal osteotomy, a chevron, a diaphyseal shaft osteotomy, then you got to come up with something else. And I'll tell you what to come up with in a second. Look at this carefully. Excessive DMAA, biplanar osteotomy. But if you don't close it down, I put this as sort of a visual so you could put it, this will stick in your mind better than my talking. The DMAA was not corrected by the biplanar osteotomy, and that's what got this patient in the subluxed joint. 15 degrees is the magic number for the DMAA. They also want you to know is you can do all kind of osteotomies. See these 3 different osteotomies, and it's still got the same deformity it started with? Why? Distal soft tissue realignment was not done. No matter what you do to the bones, you've got to make the muscles balance the bones at an unstable joint. Complications, they like to ask this. Complications of a chevron, most commonly, failure to correct deformity. Why? You tried to push the operation too far. Push it into the upper moderate to severe degree. It wasn't made for that. Mitchell, malunion with transfer metatarsalgia. That's what they want. Basilar osteotomy, no matter what kind you do, they're also going for the malunion dorsal. Now, go down here to the hallux varus, because I don't want to confuse you in the chapter. In the largest series of proximal metatarsal osteotomies and distal soft tissue repair with the longest term follow-up, the most common complication is hallux varus. It's 11 to 13%. But we're talking about 1 or 2 degrees of hallux valgus in those studies. The symptomatic hallux varus was 3 to 4 degrees. So they're not going to throw you a slider on this. They don't want you to put hallux varus. They want you to put malunion, dorsal, malunion with transfer metatarsalgia. And frequently they'll show you a second metatarsal that gestalt-wise looks real long to you. It looks real longer than the first metatarsal. What they're pushing you toward is the basilar metatarsal osteotomy healed in a little bit of dorsiflexion, and that long second metatarsal is now taking all the hit. It's got transfer metatarsalgia followed later by a hammer toe. Now, if you've got, this is a peculiar problem. I don't think they're going to throw this at you, but I think some of my foot and ankle buddies, I don't know. I like them all. I don't trust them sometimes. Anyway, you notice this, how severe this is. It's very uncommon to get this much congruity at the MTP joint when you got this much varus of the first metatarsal. So this is a rare bird. This is a severe hallux valgus with a congruent joint. Now, if you do a basilar metatarsal osteotomy and leave that, look at the DMAA on that patient. If that's one part of the articular surface, just give me that, y'all. And that's the other part. Can you see that's pointing way over here? That's a built-in hallux varus. So what they're asking you here is a double osteotomy. They're asking you for a closing wedge osteotomy distally, maybe translational too, to get a few more degrees of correction. And they're asking you for a proximal metatarsal osteotomy to correct this excessive DMAA. And they want you to get an x-ray in the operating room. In the operating room. Now, let's say this is a child, well, a 14-year-old girl, and their 12-year-old girl, and their physis is open, but severe deformity and recurrent pain, and you're operating on her. They'll mention, because the physis is open, a medial opening wedge cuneiform osteotomy with a bone graft, because they don't want you to close the physis down if they still have some growth in it. But the double osteotomy here, and either here in closed physes or here in open physes. If not, you might get this. Now, they also like this, y'all. Look over here. Do you see how this medial eminence looks scalloped out? It looks like too much bone was taken out. But do you also see that the fibula sesamoid is still in place? What they'll ask you is the most common cause of hallux varus with a basilar metatarsal osteotomy. The most common cause is if somebody's resected the lateral sesamoid. But if you see the lateral sesamoid in place, then, and by the way, that's what you'll see mostly on the x-ray that they give you. The reason is excessive medial eminence removal. That's the cause of the hallux varus. That's the button you push. If you don't see the fibula sesamoid by chance, then okay, push the fibula sesamoid resection button. Now, the recurrence of in the Keller resection, most common complication, recurrence of deformity. Most severe complication is the cock-up toe. If they show you a photograph, a clinical photograph that looks like that, and say, what went wrong with the Keller? The FHL is intimately pushed up against the base of the proximal phalanx plantarward by the pulley system. You've got to take the pulley system down to do a Keller. Well, what happened, if they show you an x-ray like this, you've got to tell them FHL was cut. That's a complication of a Keller procedure. If they show you a complication like this, which is a multiplanar clawed hallux that I'll show you in just a second, what they're asking you there is loss of intrinsic muscle flexion at the MTP joint. That's what they're asking you there. You've taken off the base of the proximal phalanx, and the FHB has lost its insertion. Don't do a fibula sesamoidectomy. That's not allowed, I'm afraid. Now, multiplanar hallux valgus, hallux varus is over here. Uniplanar over here. If they show you a picture like this, and they might, this is a uniplanar. It's primarily in that transverse plane. That's almost always supple. It's almost always treatable with just taping or even a hose. It'll bring it back to neutral. If you have to operate on that, most of the time it is asymptomatic even when it's large, as opposed to this multiplanar. It's almost always symptomatic. A uniplanar, hallux varus, supple, able to reduce it with just a sock. The operation you want to do, the button you want to push is an EHL transfer, moving the tendon, now listen to me, deep to the transverse metatarsal ligament. You'll lose its tenodesis. Well, they say it's dynamic. Let's say it's dynamic. You'll lose the effect of the EHL transfer. If they say EHL transfer, they'll say and arthrodesis of the IP joint. But they might say half of the EHL. Then you don't have to arthro. They won't give you both choices on that. It depends on who writes the question and where they train. But EHL transfer deep to the transverse metatarsal ligament. Does anybody want me to say that again? Are you okay with that? Say it again. Deep to the, you got to put the transfer deep to the transverse metatarsal ligament. If it says in the question take half the EHL, you don't have to fuse the IP joint. If they just say take the EHL, you've got to fuse the IP joint. So that'll be another choice. EHL transfer and IP joint. And that's the one you want to circle. You okay? Now, if you're doing a Lapidus, the most common complication is a malunion radiographically, but clinically you get transfer metatarsalgia. And the way they phrase it, they won't do this to you, both of these. They won't phrase it so you get confused about what they want. They'll either say a radiographic malunion or they'll say transfer metatarsalgia. Now, complications, failed total MTP joint replacement. They want you to do an interposition bone graft. A failed Keller. They want you to do an interposition bone graft. One thing I didn't tell you that I'm afraid is going to be on the exam. You see that Band-Aid? Most common symptomatic anatomical location after an intrinsic minus hallux or a varus hallux from a failed bunion procedure or Keller, pain at the IP joint of the hallux. So what do you do for this? The operation you ought to choose is an arthrodesis of the first MTP joint for the multiplanar deformity with a capsulotomy at the IP joint. If they don't give you the arthrodesis choice, do the EHL transfer and the IP joint fusion. But they'll probably want you to do the arthrodesis and the IP joint capsulotomy. Just a little comic relief. I know you're getting tired of bunions. Too much foot for too little shoes. So tell them you can't do much about that. Now, sesamoid injuries, they like that too. All of these different conditions affect the sesamoid. Don't memorize all of those. But the tibial sesamoid is most commonly injured due to weight-bearing stresses on it being more than the other sesamoid. They'll ask you for functions of the sesamoid. They'll list 4 of these, and then on the 5th one, it won't make sense. So if you can learn these, or if several of them don't make any sense, but they give you this is their favorite. Provide the fulcrum for the short flexors to have power of MTP joint flexion. They want you to get a sesamoid view. Remember now, you start doing lateral releases at the MTP, back to hallux valgus. You start doing lateral releases at the MTP joint when that tibial sesamoid is more than 50% across the crista. Now, what differentiates a bipartite sesamoid from a fracture? The bipartite sesamoid almost always will be in the tibial sesamoid. The fibula sesamoid is bipartite in only 1 to 3% of patients. The fracture will have uneven surfaces, and it might be comminuted. Now, with the first MTP joint dislocation, and they've had this on the exam too, you get a clawed or intrinsic manus hallux. Frequently, it's a high-performance athlete. Do you see? It's hard to see. I put some markers there. These sesamoids have retracted proximally, and they will almost always give you the other toe, and you'll wonder why the other toe is there. It's so you can look at where these sesamoids are lying compared to this one. So this was probably a dislocation dorsally of the first MTP joint with a spontaneous relocation followed by an intrinsic manus hallux. By the way, this can be devastating to a high-performance athlete that's making $50,000 a game. Now, take that out of your mind, that false negatives. I wrote that down wrong. False positives are frequent with a bone scan, but it can help differentiate just an irritated bipartite sesamoid versus a fracture. A fracture will have intense activity, and if they get a collimated one, real focused down bone scan, they can even tell you which sesamoid is involved. If you've got forefoot valgus, I don't know how many of you even heard that word before, but your normal resting posture is a little bit of forefoot supination. That's what we're comfortable with as orthopods. But forefoot varus or forefoot supination is normal resting. If they got resting forefoot valgus like this, then you don't, and the first metatarsal is not passively correctable past the second metatarsal when you lift it dorsally, then you can't do a tibial sesamoid shaving in a plantar flex first ray. That's the point they're trying to make. Bipartite sesamoid, 10 to 15% of the population, usually tibial, 25% bilateral. For some reason or other, they like things like this, and I don't know why. But see how smooth those edges are? That shows you that it's a bipartite. This is a tibial shaving. Again, on a weight-bearing lateral x-ray, if the first metatarsal declination angle is greater than 20 or 25 degrees on the lateral, or you can't reduce the first metatarsal past the second with passive dorsiflexion, you can't do a tibial shaving. Now, if you're going to take the tibial sesamoid out, do it not through a midline medial approach, but through this plantar approach. But what is so vulnerable is the proper branch of the medial plantar nerve. It's a long, exposed, sinewy branch of that medial plantar nerve, much like the ulnar digital nerve to the little finger that exits from beneath the palmar fascia so early. Well, this nerve exits from the plantar fascia very early, and it's very vulnerable, and it looks just like, now I'm teaching, just like the tissue around it. So when you make your skin incision, put your knife down. Now, if you're going to take your fibula sesamoid out, plantar approach, beware of the first common branch to the first web space, or particularly the proper branch to the lateral side of the hallux. It has to be pulled out of the way to do a fibula sesamoidectomy. It's right over it. But still do a plantar approach. It's easier than a dorsal approach. At least that's what I think they'll ask you to do. To bring up to you one more time, look at that hallux and varus. We're pushing, I'm cheating, I'm pushing through an open medial wound here, pushing the fibula sesamoid out, showing that if you take that out, you can get that. Now, bilateral sesamoiditis, they like this one too, in a young adult male. Think of Reiter's disease. That's not dysentery, I'm sorry, y'all. That's enthesopathy of inflammatory bowel disease like regional enteritis or ulcerative colitis. Or some, parasitic thing. Psoriatic arthritis, seronegative rheumatoid disease, and a host of other things that keep our rheumatology colleagues paying their house note. Remember, prolonged conservative treatment with sesamoid injuries. That's the answer they probably want. If they don't give you prolonged conservative treatment, extensive and all those words, stick with pads. Dancer's pads, metatarsal pads, rocker soles, stick with something. If the sesamoidectomy is the right answer, then the fracture separation should be greater than 3 millimeters and persistent pain. Now, every once in a while they'll give you, in a high-performance athlete, the option of bone grafting a fractured sesamoid. You can't bone graft it if there's more than 3 millimeters of separation or gross motion. Otherwise, if that's the case, you have to excise it. Now, I'm going to hit this pretty heavy, the synovitis of the second MTP joint, simply because they hit it heavy. And we're going to go through some of these hammer toe, claw toe, crossover toe deformities. The hammer toes may be present with synovitis, swelling of the MTP joint, tender to palpation, dorsolateral aspect of the second MTP joint, particularly tenderness at the plantar plate. Most vulnerable portion to rupture, proximal, but where they're tender is near the base of the proximal phalanx. They're tender along the plantar plate. A positive Lachman. It doesn't have to be a big positive where you can just completely dislocate it, just a little bit of subluxation compared to the other side. They might phrase it that way. And you have decreased flexion of the MTP joint due to the synovitis, swelling of the joint, and some transposition of your intrinsic flexion moment arms. Now, why did I show you this? The natural history of untreated second MTP joint synovitis is this: a dislocated second metatarsophalangeal joint. I wanted you to see that. I wanted you to see that also because what they're getting at is they want you to do this to treat it. Part of the corrective procedure is not just correction of your hallux valgus if you've got a marked crossover toe deformity, and this one it's not a crossover toe, but we'll get to that in a moment. They want you to do this: a distal oblique shortening metatarsal osteotomy. You see the marked subluxation or dislocation here, and you see the osteotomy, the translation plantarward with reduction of the joint. I think they're going to use the word with reduction of the joint rather than stabilizing the joint, because you don't repair the plantar plate. But if they say reduction or stabilizing, either way, for a dislocated second MTP joint, and they're asking you to choose a distal, one of your choices are distal oblique metatarsal osteotomy, choose it. Choose this Weil osteotomy, the distal oblique shortening metatarsal osteotomy. They'll also then come back and say, this patient has had this osteotomy for the deformity I just told you. What is the most common complication? And you're to answer the inability to flex the metatarsophalangeal joint, causing a dorsiflexion of the second toe. They can't get the second toe to the ground. Why? Look at the little marker up here. If you translate this head plantarward, the intrinsics, the first and second dorsal interossei do not go with it. They stay and they slide just dorsal because they're just plantar. They now slide normally. They slide just dorsal to the instant center of rotation of the first MTP joint. Now, the interossei cannot flex the MTP joint. They just can't do it. So you get an extension or dorsiflexion posture to the second MTP joint. That's the most common complication of the distal metatarsal osteotomy. Now, let's go to the mallet toe, and then we'll go back to the other one. I want to cover these, though. What they want you to do, look at this patient's third and fourth toes. Not too much deformity back here. Mostly is at the DIP joint. They're not asking you to do just a condylectomy of the middle phalanx. They want you to add an FDL tenotomy, either through the joint or a separate incision plantar in the midline. Remember this now. They want you to do an FDL tenotomy in addition to the condylectomy. Now, they might say, not say condylectomy, they might say arthrodesis of the DIP joint and tenotomy of the FDL. Okay, but they won't give you both. So you can either fuse that DIP joint or you can do a resection arthroplasty with a dermodesis, but you've got to add the FDL to it. They won't ask you to do both. Now, if you would, what I'd like you to do is to go in your book, your Miller's textbook review, on page 322, Table 5-6. I'm not going to go through all this because it's not going to stick with you. Let me tell you what they're most likely to answer. But I would like you just to look at that sheet sometime between now and July the 8th, that algorithm. What they're trying to get you to do is they're going to say, what is your treatment of choice for flexible hammer toe? And your answer is going to be flexor to extensor transfer. They're then going to ask you maybe a question about a clawed toe. What is your treatment for a clawed second MTP joint? A clawed toe. And your answer is going to be a distal metatarsal oblique osteotomy and an FDL transfer. That's going to be your answer. There are all kinds of ways to do it, but that should be your answer. Now, never resect the base of the proximal phalanx. That'll never be an answer. And if there's a fixed flexor contracture at the PIP joint, don't arthrodesis that joint. Do a head and neck resection of the proximal phalanx. Some of this might go contrary to what your teachers have taught you. For heaven's sake, do what they taught you. That's what works in their hands. All we're talking about is pushing buttons so that July the 9th you wake up and say, freedom. Life begins on July the 9th, and I salute all of you who are about to live on that day. Now, by the way, on the second MTP joint subluxation dislocation, if they offer a molded arthroplasty of the second metatarsal head, in other words, a partial resection of the metatarsal head, layer millimeter by millimeter until the toe goes down, don't choose it. 5 years ago, I would have had you choose a DeVries partial resection or molded arthroplasty of the second metatarsal head to reduce a severe clawed second toe. Don't choose that anymore. Choose that osteotomy I talked about. Now, bunionette deformity. If you've got a metatarsus quintus valgus, that's just a big old word to say the fifth metatarsal is way apart from the fourth metatarsal. And they very well might give you this. They might give you a 8 degrees. The intermetatarsal angle 4 and 5 is greater than 8 degrees. That's the magic number. Then you want to do a diaphyseal osteotomy, a long diaphyseal osteotomy, rotational. Now listen carefully to this. If they add to the question and there's a painful callosity plantarward beneath the fifth metatarsal head, you make that a biplanar diaphyseal osteotomy if it's got metatarsus quintus valgus. So you can correct the IM angle and dorsiflex it a little bit to take pressure off the bottom. That's for a type 3 bunionette deformity with increased metatarsus quintus valgus. If you got a type 2, which is just sort of a big old fifth metatarsal head, which, by the way, is a radiographic trick that's played on us orthopods, but it looks like a big old fifth metatarsal head compared to the fourth, you do a lateral condylectomy and you transfer the head medially with a chevron. Type 2 bunionette, chevron. Type 3, long diaphyseal osteotomy. But if you've got a plantar callosity, when you move that chevron over, you either got to dorsiflex a little bit or shave off the plantar condyle. If you've got a type 1 deformity, which is just a big old lateral eminence, then you can just take that off. That's a type 1 deformity. Never excise the fifth metatarsal head. Plantar callosity, always shave the plantar aspect of the metatarsal head or dorsiflex it if your osteotomy allows. Now, let's move over to, whenever you hear the word claw toe, in your mind think metatarsophalangeal joint. Whenever you hear the word hammer toe on this exam, think of PIP joint. It'll be interchanged easily in a lecture like this, but that's how you think. Now, let's go to the neuromas. The third web space is involved in 80 to 90% of the time. The pathologist that spends 15 seconds looking at that slide and makes more than you do calls it perineural fibrosis. The most common cause of failure of surgery is recurrence, which means a stump neuroma from inadequate proximal excision of that nerve. You need to get it about 2 centimeters proximal to the deep transverse intermetatarsal ligament. The structure on which the interdigital nerve is compressed is the transverse metatarsal ligament. For first come, it's a dorsal. Oh, always try conservative management. You always look in your question, have they tried that yet? Dorsal for the first time, resected way proximal to the metatarsal transverse intermetatarsal ligament. A recurrence is really just a glioma at the end of a nerve from inadequate resection through a little old pinhole incision. If they say a large bursa was wrapped around this nerve, they can lead you into this. I don't think they're going to do it, but if they mention bursa around an interdigital nerve, they might have you going toward the working that patient up for one of the inflammatory arthritides. So if they mention bursa, start looking in the question for, they want me to get a rheumatoid factor, or what's going on here? I better stand still. I'm feeling like a televangelist. My wife's a minister. She wouldn't appreciate me saying that, but she's not a televangelist. That's okay though, if that's your thing. The synovitis, second. The reason I'm approaching this again is it can be confused with a second web space neuroma. But the area of tenderness, for one thing, to separate them out is you've got tenderness at the capsule, but remember that's not a centimeter away from your web space. Further attenuation of the plantar plate will give you some instability of the joint. So A is nerve and B is joint, and it has a positive Lachman. Now, if you've got a crossover toe deformity, a COT, cot deformity, if you've got that and a severe hallux valgus and that old second toe is hanging over the big toe, you've got to correct the hallux valgus. Now listen to me because this will throw you off. This is out of kilter with the normal wording they use. They'll use the bunion deformity is asymptomatic. You still got to correct it. You got no place to put the second toe. And by the way, when you get back home, you make sure your patient, understands. I know it doesn't hurt, but you live with this, or we got to correct the big toe too first. And you don't have a painful big toe. When I get through with you, it might be painful. And then see if they want to do it. But on that test, push the button that says hallux valgus correction and second toe. Just remember, with an FDL transfer, the tendon is always below the deep transverse intermetatarsal ligament. In other words, leave it where it is. Now, the treatment non-operatively is a steel shank rocker sole or a metatarsal pad. Now, they might walk you down this way. A cortisone injection might give what? Well, it can result. You already got a compromised capsulo-ligamentous apparatus around the second MTP joint, including the plantar plate. So you put a cortisone shot in, you reduce the inflammation, you might develop a hammer toe from your cortisone shot. Sometimes they'll ask you that. Now, every once in a while they'll throw you a funky-looking X-ray like that. I think that'll just gestalt Freiberg's teenage girl. In an adult, they'll throw you an enlarged metatarsal head, reduced MTP joint motion, become painful. She noticed it when she was 18 and now she's 36. That's Freiberg's. They might not even give you an X-ray on that, just the history. Asymptomatic since a teenager or minimally symptomatic. Now I got a big knot on my foot, doctor, at the second metatarsal head. That's Freiberg's. Now, tarsal tunnel syndrome, anterior tarsal tunnel syndrome, upper motor neuron. Let's go over some of this, y'all, because they hit it pretty hard. Poor correlation between EMG nerve conduction and the clinical outcome. The earliest, put this in your mind, the earliest nerve conduction velocity abnormality is a sensory latency, increased sensory latency, not motor, in the lateral plantar nerve. The earliest abnormality in an electrical study. Don't get your electromyographer into all this discussion. Don't even go ask them. They'll tell you 20 reasons why that's not right. You just want to push that button right there. Best results after release of the transverse retinacular ligament, space-occupying lesions, old osteophytes from from trauma and periarticular trauma, neurilymomas, ganglions, big old venous clusters, etc. They also like to ask you all these studies and then say, but is this really a clinical diagnosis? And your answer is yes. That's how you diagnose it. With repeated examinations over an extended period and getting to know the patient real well. And if your studies corroborate what you feel is the right thing to do, fine. If they don't, you're on safe clinical grounds for that patient, which is most important, but you're also safe medical legally to operate on that patient. Now, they like to ask that you better take down the abductor hallucis. Remember, the innervation has been the proximal third, so you can do this. Take it down in order to get the distal release. They love to ask that question. This was a neurylymoma of the lateral plantar nerve. Now, remember, anterior tarsal tunnel syndrome is deep perineal nerve. Deep perineal nerve, not superficial perineal nerve. Impingement beneath the distal margin of the inferior extensor retinaculum. There's a medial inferior limb of the inferior stem of the inferior extensor retinaculum. How'd I get into all that? It's the distal edge of it. Now, dorsal osteophytes over the apex of the medial longitudinal arch. Now, if they've got a young athlete, and he's not having superficial perineal nerve symptoms from ankle sprains, he's having numbness in his first web space when he runs. Well, first thing you do, I'm teaching, tell him to loosen his shoe up some. But they're asking you for entrapment up around the ankle, superior extensor retinaculum, not inferior. It's the people my age with bumps on the top of their foot that they're asking you for inferior extensor retinaculum. Those with degenerative arthritic change. Y'all have all seen them in the office, the big knot up there, and you get an x-ray and you can't see it on the lateral view, and you know it's there because you just examined it. Those are points of entrapment right there. Now, this is what they're going to ask you about the stroke patient, the stroke patient or the young, the, heaven forbid, 32-year-old mama of 3 with a hemiparesis from a stroke. They're going to ask you, what do I do? What you should do for that patient. Well, number one, you wait a year before you do anything. You brace them, splint them, and you be a doctor to them as much as you can. And then equinovarus deformity of the ankle and foot in a patient with a CVA, split anterior tibial tendon transfer, and a gastrocnemius recession. Now think with me just a minute. I'm going to go off of this upper motor neuron, and we got a 33-year-old motorcycle, a 23-year-old motorcycle rider. He falls off. He gets a stretch injury of his perineal nerve at the fibula neck. He's got a drop foot. It sort of wakes him up. He goes back to school, and in a hallucinatory moment, even goes to medical school. He becomes an anesthesiologist. He's tired of his brace. He's got a supple ankle and forefoot, hindfoot, midfoot. What they're asking you to do is a posterior tibial tendon transfer through the interosseous membrane. That's what they're asking you to do, but not in an upper motor neuron injury. They're asking you to do a splat. They're also asking you to add a TAL if there's if there's an equinus deformity of greater than 10 degrees, and they want tenotomies, tendon lengthenings, and fascial releases. They don't want arthrodeses unless there's just no other way to go. Now, CMT, remember this, weak tibialis anterior, strong peroneus longus results in a plantar flexed first ray. What is the opposite of that? What if you had a strong TA and a weak PL? Would you get a dorsal bunion? So put that up in your mind too. We're not talking about dorsal bunions that come from polio or something. We're talking about CMT here, hereditary motor sensory neuropathy, and as far as our orthopods, day in and day out activities in our clinic, that essentially means CMT. All right, the plantar flex first ray. When that plantar flex first ray occurs, it then drives the hindfoot into varus. So this is forefoot equinus from muscle imbalance between the TA and PL. Why the PL is spared in many patients with CMT, particularly type 1, I don't know if anybody knows that. But it's been proven electromyographically with muscle biopsies and clinically. So let's just take it for that. The PL is strong. The forefoot goes into plantar flex first ray, forefoot valgus. The only way the hindfoot can get into weight-bearing position is to go into varus. So the hindfoot is driven by forefoot equinus. That's what they want to ask you, want you to know. The weak peroneus brevis and a strong posterior tib, which is its antagonist. The antagonist to the PB is the posterior tib. You get an adducted forefoot and then a plantar fascia contraction. You get the whole shooting match. Remember, recurrent ankle sprains in a teenager playing sports. Test that peroneus, the peroneals. They'll come in not even knowing they got anything. Just my ankle keeps giving away on me. You've got to test them for, digression a moment, tarsal coalition and weak peroneals. You've got to do it. If they show you a foot like that, that's called global cavus. The calcaneal pitch angle, I'll show you in a minute, is excessive. Forefoot equinus. Most patients with CMT will have forefoot equinus, but no hindfoot calcaneus. This is hindfoot calcaneus. And that's in polio. Now, out of the last 5 years of OITEs, 3 of them have had the Coleman block test on it. Whether it'll be on your exam or not, I don't know, but it's for it. Determine the fixed versus flexibility of the hindfoot. If there is a flexible... Any of y'all from Utah? Nobody from Utah. Where Sherman Coleman did a lot for all of us, y'all. Hindfoot supple. Can you see where the first metatarsal hangs off the medial border of that board? When that falls down, the hindfoot goes into neutral position, then you know it's not a fixed deformity. And that's what they're getting you to know. Fixed versus supple deformity. Because it changes your treatment algorithm. Do not forget the sensory component of hereditary motor sensory neuropathy. You may have ulceration. And by the way, they might ask you something like this. Non-union in an ankle fusion in a CMT patient times 2. Where they're going with that is a Charcot-arthropathy, like a diabetic. That's where they're going with that. And that's the button you hit. Calcaneal pitch angle, you probably ought to put that somewhere in your mind. Greater than 30 degrees is abnormal. At least until July the 9th. The autosomal dominant form of CMT, duplication of chromosome 17. Maybe our pediatric faculty member will give you this. I don't know. I didn't know what to do here. But duplication of chromosome 17. Now, the peripheral myelin protein 22, write that down. PMP, peripheral myelin protein 22 in the type 1 autosomal dominant CMT. That's the abnormality. The myelin sheath is markedly abnormal. The nerve thickens, and write this down. Nerve conduction velocity is negative. It is abnormal. Nerve conduction velocity abnormal in type 1, but in the neuronal type 2, it very well might be normal or minimally abnormal. I don't think they're going to ask you that, but they might. Now, what I want you to do is the next 3 slides on hereditary motor sensory neuropathy. I want you to forget. They're just not going to ask you sex links, and they're not going to ask you Desjardins-Sotos disease. So just forget it. Just remember this slide. And one more visual to show you why the hindfoot is correct, is thrown into varus with a plantar flex first ray. You can see how that happens like that. Now look down in the post-polio. See that calcaneal pitch angle is real high? In idiopathic, it might be high, but in the CMT patient, the calcaneal pitch might be normal. That means forefoot equinus as opposed to global equinus is characteristic of CMT entity. Now, usually in poliomyelitis, the extreme calcaneal posturing of the calcaneus is from a weak gastroc soleus. Before I forget it, in post-polio syndrome, sometimes they'll show up in the foot and ankle practice, and in yours too. Just treat them conservatively. It's just they don't have any reserves left, and that's what they might ask you. Bracing if the patient can stand it again. Inserts. Gentle, they'll put the word gentle PT in there. But don't operate on them unless they're so unstable and just unbraceable. That's the only indication for surgery is instability and malalignment that's fixed. Always think, in the summary of this pes cavus deformity, flexible versus fixed, and arthrodesis is a last resort. That's where they want you to go with that. Well, I got ahead of myself there. Now, rheumatoid arthritis. They always seem, well, they seem to have that down there pretty frequently. Something going on with rheumatoid arthritis. Rheumatoid factor positive in 80% of the patients. Most common presentation in rheumatoid forefoot is metatarsalgia. The painful callosities are due to hyperextension deformities of the MTP joint. Now, recurrence of callosities is the most common complication after forefoot surgery because of insufficient resection of the metatarsal heads and necks. Recurrence of callosities, most common complication after forefoot surgery. You take those out, you get bursae back, either beneath one or two because they're not resected back far enough. Excessive heel valgus, they might be asymptomatic. If the question reads forefoot symptomatic, hindfoot and marked valgus, but asymptomatic, they don't want you to operate on it. Also, hindfoot valgus in the rheumatoid is not due to rheumatoid or due to posterior tibial insufficiency most of the time. It's due to insufficiency of the talocalcaneal interosseous ligament, and that's what they're looking for. It's a synovial line ligament. It's an enthesopathy. It gives way, and then just weight bearing forces the heel into valgus. They're looking for talocalcaneal interosseous ligament insufficiency with hindfoot valgus. I only operate on the forefoot if the hindfoot is not symptomatic. The treatment on the forefoot is arthrodesis of the first MTP joint and resection of the metatarsal heads, 2, 3, 4, and 5. Most common cause of failure over triple arthrodesis is failure to correct excessive hindfoot valgus malalignment. On the right, we've got inadequate bone resection. On the left, adequate bone resection. Now, I'm not going to go through the crystal-induced arthritis. I just think the basic science people will pick up on that. We certainly see them fairly often in the foot and ankle practice. The seronegative spondyloarthropathy, they might show you a sausage toe. It's that reddish, purplish third or fourth toe, and a lady, well, it could be man, the 30s, 40s, never symptomatic before, spontaneous onset of a swollen, purplish red third or fourth toe called dactylitis. You've got to think of psoriatic arthropathy, and that's the peak age. They'll ask for, the patient has nail pitting, but no skin lesions. It might precede skin lesions in 20% of the patients. Reiter syndrome is basically an enthesopathy to y'all. Achilles tendonitis, plantar fasciitis, rarely indicated for arthritis, and they want to know that the HLA-B27 is highly positive, 95% and 90% in ankylosing spondylitic patients. 4 out of 5 will be males. Now, they might hit this. I think this may be the only medical thing that foot and ankle surgeons get to play with. So they hit this pretty hard. It's a spirochete. It's got a red even 5 centimeters. Great big lesion. Red circle with a white center. They'll give you a history of vacationing, deer hunting, a tick bite. Might mention Connecticut, where it was described. The treatment is doxycycline or amoxicillin. If they're not allergic to penicillin, you can give them amoxicillin and doxycycline. The ID guys at our place are starting to give cephalosporin, but don't circle that. It takes 5 to 6 months for serologies to turn positive after the inoculation. It is a vector-borne, fleas or something, vector-borne disease. Hallux rigidus in adolescents, it's from an osteochondral injury. In adults, it's from osteoarthritis. Natural history, progressive loss of motion until they usually become asymptomatic. Remember this classification, its only use is treatment. They'll say a type 1, no joint space narrowing, minimal loss of motion, you use a bar. Type 2, still got some joint space left, prominent osteophytes. Now, you want to do a chylectomy if they say something like this. Pain is mainly with dorsiflexion of the hallux, and there is a dorsal osteophyte. That's when a chylectomy is primarily used. But if they show you in a blank x-ray and there's still some joint space all the way from top to bottom, they probably want you to do a chylectomy, even though the AP shows some periarticular osteophytes and the lateral shows a dorsal osteophyte. They probably want you to do a chylectomy if you've got any joint space left. Now, if they give you a runner with a dorsal osteophyte abutment, and they've got only about 30 or 40 degrees of MTP joint extension, and they emphasize that runner, young runner, competitive runner, they're pushing you toward a Moberg. Take off the dorsum of the first metatarsal head and a dorsal closing wedge, proximal phalangeal basilar osteotomy. That's been on the exam, and they'll lead you to that with runner and young because they need 60 degrees of dorsiflexion, well, 50 or 60, to compete competitively, to run competitively. Now, pes planus is almost always on this exam going to end up either in a pediatric section with the pedipod's with flexible pes planus in the child, or it's going to end up with a posterior tibial tendon insufficiency in the adult. That's where they're going with this. They want you to differentiate flexible and rigid simply because they want you to do this. It changes your treatment algorithm. Rigid, arthrodeses. Flexible, osteotomies, tendon transfers. Tenotomies if the TAL, if the tendo-Achilles is tight. You got to be careful to check for undiagnosed tarsal coalition. Acquired pes planus, almost always, and for our purposes, posterior tib insufficiency, and it progresses gradually from flexible to rigid. They love to use these words. If it includes mildly, intermittently, occasionally symptomatic, always choose non-operative function. Multiple insertions. They want to ask you all the insertions except the base of the proximal phalanx. That's the only one it's not on as far as the tarsus metatarsus is concerned. The posterior tibial tendon muscle tendon unit is a dynamic stabilizer. It is behind the ligaments and it's behind the windlass mechanism. Now, they might ask you this. What happens in this deformity when the heel goes out into valgus and posterior tib insufficiency? What they're asking you is to think in a triplane way. They're making you think dorsiflexion in the sagittal plane, the calcaneus. Now, this is all relative to the talus. Dorsiflexion of the calcaneus, eversion in a frontal plane, and abduction of the calcaneus in a transverse plane. That's what they're asking you to do. This is normal, and this is the posterior tib insufficient foot. Now, in your book, I have 20% incidence of patients remembering a traumatic event. It's somewhere between 25 and 35. In other words, 1 out of 5, 1 out of 4 patients will remember a traumatic event. That's what you should circle. They like this one. The reason most tendons give way where they do, most posterior tib tendons, is This is the at-risk zone between the, because the vinculae are up here, between the medial malleolus and down here, and the tuberosity of the navicular. That's the at-risk zone for rupture. Now, it's about time for them to give you one of these. I hope they don't, but it might happen. And this is a fastball. This is not a curve. This is a legitimate thing. But it hasn't been on the exam before, but I just think it's about to hit. The marked 90 degrees flexion of the talus. But yet this patient, believe it or not, can have a completely supple hindfoot, midfoot, forefoot. Rare, but can happen. What they're asking you for is a double osteotomy. They're asking you for an Evans and a calcaneal slide osteotomy with marked deformity. They'll use that word, and completely supple joints. They're also asking you for an FDL transfer immediately. Now, spring ligament, we talked about its origin insertion. The superomedial portion is the part that gives way the most frequent, part that gives way with posterior tib insufficiency. Always check for a tarsal coalition. They like that too many toes sign. Remember we talked earlier about you can't get from an everted position, you can't get to an inverted position without recruiting the anterior tib if the posterior tib is out. Always, they'll ask you about heel rise, and the heel stays invalgus. Another good sign, particularly unilateral heel rise, that the posterior tib is insufficient. They stage it in order to treatment recommendations. In other words, if there's a tenosynovitis, you treat it, of course, non-operatively, all of these, until they don't give you any other option. And this is just with inserts. This is all, just treat this with inserts here. What they want in the stage 2 in a flexible deformity, this is what they want. They want a calcaneal sliding osteotomy and an FDL transfer. If they lead you down the path that there's an equinus contracture, they want you to add a TAL. And in your practice, go on and do it. Stage 3, fixed deformity, they want you to do an arthrodesis. Stage 4, I'll show that in just a moment. They might want to know about the talar declination angle. The larger this angle becomes, it's an angle between the longitudinal axis of the talus and the plantar surface of the weight-bearing foot. The larger this angle, the more severe the deformity. They'll talk about the talonavicular coverage angle, but they'll never give the specific values for it. They'll just say it's increased. I didn't want you to get confused by that. Yes, MRI might be helpful, but what they're trying to lead you into is this is a clinical diagnosis. If your MRI shows a normal posterior tibial tendon, but you know that patient has a plano-valgus deformity, they've got swelling and tenderness around the posterior tib tendon, you've treated it for months and one way or another, and they're still symptomatic, you can have some false negatives and false positives on this study. Differential diagnosis are these, and they want you to treat it. Let's say you got a 70-year-old. You put her in a cast for 6 weeks, much less symptomatic, but still some symptomatic. She does not want any surgery. You start off with a molded orthosis. Probably nothing's going to help that lady that doesn't go above the ankle. But for your test-taking purposes, you start off with a molded orthosis unless she has a fixed component to her deformity. She's still symptomatic after casting. She does not want surgery, and they'll lead you to a brace with fixed deformity. Flexible deformity, still symptomatic, don't want surgery, don't go to this or even an AFO. Go to this. That's what they want, a molded shoe insert. Surgical management, tenosynovectomy for stage 1. For stage 2 disease, even severe disease, ruptured tendon or post-stenotic extreme injury to the tendon, chronic healing of the posterior tib with scarring continuity. That's the FDL, FHL over there. It's a long way over there, by the way. Stage 2, even with marked deformity, if it's completely supple, they want a calcaneal osteotomy. But in the adolescent flexible pes planus, that you've done everything you can to and they want surgery, they want a lateral column lengthening. If they ask you if it's a lateral column lengthening, and if they say it in an adult, it's done through the CC joint, calcaneal cuboid joint, the most common complication is a non-union. But if they phrase the question, lateral column lengthening, what is the most common complication? This is with an Evans, a distal calcaneal osteotomy or a CC joint. The most common complication is lateral column overload with callosities beneath the fifth metatarsal head or fifth metatarsal base. Most common complication in an arthrodesis, in a CC, a distraction fusion at the CC joint. Most common complication is non-union. Most common complication, if this say lateral column lengthening and don't give you the type of procedure, lateral column overload. Marked deformity, fixed, triple arthrodesis. Forget these next, these talar-navicular and the subtalar and the double. They're not going to ask you all that. I don't believe that. They're in the literature, but I think they might substitute a double for a triple, but you'll get the hint. And they won't give you both. They won't ask you both. Now, for a stage 4 means the talus is tilted into valgus at the ankle joint, and the lateral side of the ankle joint has gone to pot. And they're asking you for a tibiotalo-calcaneal arthrodesis through one way or another. Now, 6 or 8 weeks postoperatively, the patient has acute onset of pain where they've been essentially pain-free. It's at the distal tibia. It's a little red. It's tender, a little bit of swelling. They're asking you to get a bone scan for a stress fracture at the upper end of the nail or at a screw head. They're asking you to get a bone scan if that's a scenario 3 months later when they've had a period of asymptomatic time. This is the summary for posterior tib insufficiency, and I wanted to tell you which well, I thought I wrote it down. Which table? It's in the textbook. The table in the page. I thought I wrote it down, but I didn't. Now, in a kidney procedure, all they want to know is this: you don't have to advance the posterior tibial tendon. You can just take off the bone, the prominence, and sew the capsule back. Bring the posterior tibial tendon right back up to its normal position. You don't have to advancement. I don't know why they like that so much, but they do. Peroneal tendon pathology, peroneus brevis tears, split tears, longitudinal split tears of the peroneus brevis most commonly occur at the fibular groove. At the fibular groove. And the initiating event is probably insufficiency of the SPR. Superior peroneal retinaculum allows it to climb up over that sharp edge of the fibula. Peroneus longus tears almost always are at the calcaneal cuboid groove. To have an isolated PL tear with a normal-looking PB at the superior peroneal retinaculum is very rare, and I don't think they'll hit you with that. So think PB, SPR is where they're going to be injured. PL, cuboid groove. Have I gone through that too fast? Does that sort of make sense? Are you okay with that? Now, see that third bullet, complete rupture? I got that all mixed up in my writing all that out. So forget that one. But anyway, if 50% of peroneus brevis tear, or less than 50% tear, you tube a longitudinal split of the peroneus brevis. That's your treatment. If it has 50% tear, or if it's frayed even more than that, you just take it down and put the proximal end into the peroneus longus. Now, this fibular groove they talk about so often probably comes out of a study that hasn't been beaten since, and that's in 1928 from Edwards, and that is 82 in OKU 3. Now, this is OKU foot and ankle, not OKU 6 editions ago. 18 to 28% would be flat or convex. In the original study, it was about 18%. So you might want to keep that somewhere in your mind. This is a classification, an algorithm that I also, there's a chart, a table for that to go over. But peroneal tendonitis without subluxation should be treated with just a non-operative walking cast. Type 2 peroneal injury is similar to type 1, but involves some subluxation of the peroneal tendons, usually younger than type 1, very athletic. Incomplete intersubstance tear, fraying of the tendon, repair the SVR, deep fibular groove, and repair longitudinal tears. Type 3, both tendons might be gone. You might have the PL rupture and the PB intact. You rupture usually at the cuboid groove with a PL, and the os peroneum is ossified in about 15% of the cases, and you might see it retracted up around the calcaneus. I'll show that in a minute. If they tell you that the patient has fixed hindfoot varus and both tendons are ruptured, you need to do a calcaneal osteotomy, closing wedge, a lateral ankle ligament repair, and try to find one tendon distal and one proximal to get a motor and sew it together. See that bone retracted up here? If they show you that x-ray, that's a PL tear, because they picked out one that had an ossified os peroneum and it's retracted proximally. You see a little bit of cavoid looking to that foot? That's how most of them will look with a PL rupture. Most common complication neurovascular-wise, sural nerve damage. If they throw at you a prominent calcaneal tubercle, that's here. That might fray both tendons. That's rare, but if it's the calcaneal peroneal tubercle, remember, it's not the SPR, it's not the cuboid groove where the PL goes to the base of the first. It's this big prominent bone. All of you have seen them. Sometimes you're so big you can see them literally, visibly. Just they take the shoe off and you see it. That can fray both tendons. You've got to remove the peroneal tubercle and repair or transfer the tendon as needed. Now, anterior tibial tendon injuries. If it's a young to middle-aged person, look for an inflammatory arthritis. However, if an elderly patient comes to your office and says, I've got a tired foot, I've got sort of a floppy foot, I had a lot of pain down in my foot for several weeks playing golf and tennis, but now I don't have any pain, but I got this tender knot, and it'll be up under the, just distal to the superior extensor retinaculum. That's a ruptured anterior tibial tendon. Every once in a while, you'll have a soccer player with a ruptured anterior tibial tendon and maybe even a bony avulsion. Well, young people, of course, they'll lead you down the path to go on and repair those. But in the elderly person, what they're looking for is a brace, a cast, and then a brace, and non-operative treatment because it's an attritional rupture, it's insertion into the medial cuneiform and base of the first metatarsal, and it's the devil to sew, and it's the devil to get the length of the tendon out. There's some controversy on that, but the button you push is non-operative. Don't inject them. Posterior ankle pain. Now that can be a problem. Let's go to the ballet dancer. Posterior ankle pain in the ballet person, the dancer, the serious dancer. You might have some tenderness posterolaterally at the lateral process of the posterior tubercle. Remember, they like to ask this. The os trigonum, or the posterior tubercle of the talus, is lateral to the FHL. Now, I mean, all of you know that, but just don't get tripped up on that. It's lateral to the FHL. They get posterior, they'll tell you in the question, they get pain on point. That's FHL impingement. It could be os trigonum syndrome, but they'll give you an x-ray. Sometimes they'll give you an MRI, and they'll give you a T1 weighted image, and the talus will be white. The os trigonum, a big old outline of some bone back there, and you say, well, that looks like it ought to be the os trigonum. It'll be black. And they're leading you down the path of os trigonum injury in the ballerina. No bunion surgery for them, and if they have that burst fracture of their fifth metatarsal, long diaphyseal with a butterfly fragment, and you think, oh my gosh, their career is ended, you do what Dr. Hamilton in New York tells them to do, soak it in their helmet. But anyway, that's a World War II. You don't operate on it. That's the bottom line. You don't operate on dancers with diaphyseal fractures, no matter how bad they look, in the fifth metatarsal. And they want you to know that so you don't get into trouble. They don't. That's not even a slider or a curve ball. They just don't want you to get in trouble operating on them. Most common cause of recurrent ankle sprains, weak peroneal muscles. To repair the FHL. Now, if they get a Coke bottle laceration and it's out at the IP joint, they come in 8 weeks later to your office. That's what they'll give in there. You don't repair the FHL in the critical area pulleys. You repair the FHL if they step on something and they're cut back proximal to the pulleys. Even that's a hard dissection. But the answer to that is repair it if it's proximal to the MTP joint, the laceration. Don't repair it if it's not. If you've got a nodular a tendon FHL with a nodule in it, you'll have some triggering at the IP joint. They might give you that. If it triggers at the IP joint, think posterior tubercle, posterior process, os trigonum, impingement back there where the posterior talofibular ligament hits the lateral process of the talus and then has that pulley that goes on across. Chronic insertional Achilles tendonitis, what they're really getting at here is if over 50% of the tendon is involved, by the way, let me stop just a second. If you've got, sometimes they'll come up with this. The origin of all this starts at the anterior aspect of this tendon. Destroyed retrocalcaneal bursa from chronic inflammatory and collagenous repair, but most of the tendon, the bad tendon, is anterior. They want you to get a lateral x-ray before you leave the operating room to see how much bone you've cut off. They might lead you down that path. Say, I want a lateral x-ray. Now, this is something different. If you've got more than 50% of the tendon involved, what they want you to do is to take it down and do an FHL transfer. And if that sounds a little bizarre to you because you're just not running in these foot and ankle circles, that's what they want you to do. And that's what they want you to do on the exam. And I don't know of anybody, I don't even know who writes the questions now, but I can't imagine anybody writing those questions in the foot and ankle circles. The answer is not more than 50% of involved, big hunk of bone in the tendon, you take it down and do an FHL transfer. Right or wrong, that's the button you push. If the whole tendon is involved, you take all that down and do a transfer. See that big glob of ossification there? You do it. That'll be pretty straightforward. I don't think they're going to ask you that. Now, do you see between these two black lines this sort of bulge with a reduced signal in the anterior portion of the tendon? This is the garden snake that swallows the mouse trick. Good tendon, bulging tendon. If more than 50% of that tendon is involved, you also got to take it down and do a tendon transfer. If up to 50% is involved, you core it out and suture back what you cored out. Seems rather radical, but that's what I would circle on the exam. The bone spur is a result of the condition. Recurrent chronic insertional Achilles tendonitis, inflammation, scar, cartilage metaplasia followed by osseous metaplasia. You got a bone spur that didn't cause the problem. It's a result of the problem, but you got to take it out if you're there. They probably want you to do a midline incision and take down up to 50% of the tendon. You don't have to do a transfer, and they wanted you to do through a midline posterior approach. That's probably how they'll word that. I wouldn't worry about Haglund's. It's just too confusing. These lines are too poorly reproducible from center to center radiographically. But I want you to know on this MRI just what a Haglund's is. And they're going to show you Achilles tendon. Well, I don't think going to show you, but if they do, Achilles tendon attenuation, do a prominent posterior tubercle of the calcaneus. You debride some tendon, you take this off, and you get a lateral x-ray. That's what they want to get at. Get a lateral x-ray in the operating room. Plantar fasciitis, I'm probably going to lose you all if I start talking about that. You just stand so much of this stuff. Don't do an endoscopic plantar fascia release. They're not looking for that. I'm not saying there might not be a place for that. I'm not up here to say that. I'm just saying don't do it on your exam. Now, you've got your runner, and they've got tenderness not at the origin of the plantar fascia, plantarward and medially, but their tenderness is up on the medial edge of the calcaneal tuberosity. There, they've got entrapment of the lateral branch, the first branch of the lateral plantar nerve, Baxter's nerve, and they're getting some neuritic symptoms down into the plantar surface of foot, which, by the way, might be neuritic symptoms in the hallux and second toe, medial plantar nerve sensation. But nonetheless, they're looking for the first branch of the lateral plantar nerve, which innervates what? The abductor digiti quinti. High-performance athlete, releases okay, requires incision. That's what they want, incision of the deep fascial envelope of the abductor hallucis. What it really is the tendon of origin of the abductor hallucis. Prolonged conservative management, all of those things. If they offer you several choices as far as stretching, choose tight Achilles. Just go on and choose that. One steroid injection, try to protect it. Tell them they might rupture their plantar fascia. If they rupture their plantar fascia and then they get pain over the cuboid and lateral cuneiform, they're leading you down the path of loss of medial column support, overload of the lateral compartment, lateral column, and you got a stress fracture or a stress reaction of bone in the base of the fourth, cuboid, base of the third, lateral cuneiform, and they want you to get, they might show you a bone skin that's hot over there. You got to think to yourself, the plantar fascia, steroid injection, rupture, maybe that's what's giving the dorsolateral foot pain in this patient that had recalcitrant plantar fasciitis. They like to ask this. The nerve to the abductor digiti minimi, the first branch of the lateral plantar nerve, goes between the quadratus plantae, it has two heads, this is a medial head, and the flexor digitorum brevis on its course. They like to ask which two muscles this nerve traverses the hindfoot. By the way, it runs right under that heel spur if they've got one. It's interesting to dissect it out. Most common complication, medial plantar nerve injury with this procedure. I don't think they're going to ask this, but if you do a partial plantar release with an endoscopic release, you must see the flexor digitorum brevis muscle. That's the FDB, okay? FDB muscle. You must see it or you hadn't done the release you need to do. I don't believe they're going to get into central and post, you know. Now, diabetic foot. Absolutely, I don't know of any test that hadn't had this on it. So let me go through some questions that they're almost surely going to ask. How much time have I got before y'all all fall out of your seats? 20 minutes? 30 minutes? I don't blame you. I wouldn't tell me either. All decisions depend on calcaneal flow. Now, what they're looking for is an ischemic index, an ankle brachial index of 0.5 or more. When you get out and practice, make sure it's 0.6 or more. That's what they're looking for here. And they're looking for pulsatile flow tracings, means abnormal and not normal triphasic waveforms. The best test, if you don't see ossification on an arteriogram, or on a plain film, of vessels all the way out to the toes, if you don't see calcification in the media of the vessel, the best test is toe pressure, and it needs to be above 40 millimeters of mercury. Good healing, greater than 80%. Transcutaneous oxygen, somewhere in the 30 to 40. In your text, I put 40 millimeters of mercury because I didn't want you to get in trouble with lower. But the literature would indicate 30 to 40, you got an excellent chance to heal. Over 40, you should heal a transmetatarsal amputation. This is how they do it. Now, you ought to just look at Dr. Wagner at Rancho Las Amigas in the orthodiabetic clinic. Came up with this after extensive experience with this. Just look through it. It's on page 342, table 510. The bottom line is they want you to breed it till it's a surgically clean, not a bacterial microscopically clean wound, a surgically clean wound, and then a total contact cast. Remember this, the total contact cast to heal a diabetic plantar ulcer reduces axial load pressure and reduces shear stresses around the ulcer. That's how it works. Axial loading reduced, shearing reduced. Now, it's about time for them to start asking Jim Brodsky's depth ischemia classification. In my heart of hearts, I don't think it's going to be in there. It really doesn't make much difference. Look down here where it says pressure relief. That's because he puts them in a 3D boot instead of a total contact cast. I think I would just stick to the Wagner classification. If they throw at you this Brodsky classification, don't let it throw you. Just think Wagner classification. And put some of that up in your mind, particularly stage 2 and 3, because 4 and 5 are gangrene. You know you got to do an amputation, and you just got to know your toe pressures or oxygen tensions. So it's 2 and 3 is all you have to really remember in that classification. Now, if they've got an, do y'all remember an in-training exam question in 04, which I don't think they're going to give you? There's an IP joint ulcer and a diabetic, and the answer was subhalical sesamoid excision. Any of you remember that from 04? In-training exam? Well, that's what it was worth. Not a single one of you remembered. I don't know where they got that question. But if they've got an IP joint ulcer that's right in the midline, right here, and they show you an AP x-ray, look carefully through the IP joint and you'll see a little sesamoid bone. They're leading you down the path of a subhalical sesamoid excision. And we raised Holy Cain about that question, so maybe it won't come back again. I don't know about that. But nonetheless, subhalical sesamoid in the midline of an ulcer, it might be a choice. What they want, though, what they really want with an IP joint ulceration here is they want a Keller resection. They want to, believe it or not, they want a Keller resection to reduce push-off pressure at the IP joint, and then a total contact cast. This is what happens with a total contact cast. I just wanted to give you a visual. Stick it in your mind. It'll make you use that because that's what they want. Most ulcers beneath the metatarsal head will heal with debridement, good blood flow, debridement, TAL, if added to TCC. If they add the choice of a tendon Achilles lengthening with your debridement and total contact cast, choose it. Because there's so much data, and I just think they want you to know that with the TAL, reduced forefoot pressure will heal that ulcer. But you've got to continue the total contact cast and the surgical debridement. Now, for protective sensibility, what they want you to pick is Sims-Weinstein monofilament 5.07. It's a logarithmic number. It has no units. So it's just 5.07 Sims-Weinstein monofilament screening method for protective sensation. Now, the lab test that's most predictive of an ulcer that's present, that you see, is the serum albumin level, or they might give you pre-albumin level. They might give you that. But serum albumin level. But now, you've got a healed foot with loss of sensation and a diabetic patient, and they ask you, what is the greatest risk factor for ulceration in a diabetic foot with neuropathy? And it's a history of a previous plantar diabetic ulcer. Not the ischemic index, not the transcutaneous oxygen. What they want you to do is this. Previous ulcer is the most predictive sign that there's going to be another ulceration. That foot's at risk for another ulceration. If they ask you how to correct a common deformity after a Chopard amputation, choose an Achilles tenectomy or a TAL. Both of them will not be answered. Now, Charcot-arthropathy, I think you need to look at Eichenholz's definition. His classification, page 342, table 510. I just think you ought to run through that. Stages 0 to 1 and moving into 2. 1 and 2 are your inflammatory phases. Big old red, swollen foot that looks infected that you get called for your consult on. It's not infected. That takes total contact casting, non-weight bearing, until you enter a good, stable second stage. Eichenholz stage 2, which is the coalescent phase. Then you can start them weight bearing, but it's protected weight bearing in a brace or a cast. They want you to know, how do I differentiate infection from Charcot changes? Maybe there's no good way to do it. But what you circle is this. What you push is this. Indium label, white blood cell, technetium study, a scan, combined with an MRI for specificity and sensitivity. You combine those two. That's what you want you to do. If they don't give you combined with MRI, pick the white blood cell label indium scan. The consolidation phase is stage 3. I think you ought to at least look at it, y'all. Now, I'm going to mention this because, and I'll bet you your trauma people will, but you've got a diabetic patient. They got a bimalleolar fracture subluxation dislocation of the ankle. They tell you in the question that there's a neuropathy. You still fix the fracture, just like you always would. But you protect them and you protect them and you protect them, and that's where the question is leading you. 4 to 6 months, non-weight bearing, touchdown weight bearing, just extreme, more than you even think. That's what you choose. That's the button that you push. But you go on and fix them. I think that, I don't know if the adult reconstructive people get to it, but you've got to know the angles to arthrodesis your ankle. You just have to know how to do that. That they can ask you that. The triple, you got to know where to, what position to put that subtalar mid-tarsal joint in. And remember, if you're in too much hind-foot valgus, it's your deltoid ligament that gives way. And finally, the lateral aspect of your tibio-talar joint. This is the position for your subtalar fusion. You've got to think of 3 planes when you do a mid-tarsal arthrodesis. Remember this. If you fuse a subtalar joint, you're going to have 50% of your mid-tarsal motion remaining. You fuse just the TN joint, you're going to have 90% of your subtalar motion taken away. If you fuse the CC joint alone, like a lateral column lengthening and a posterior tib insufficiency, you will still have 70 to 80% subtalar motion after a CC fusion. Don't ever arthrodesis the 4th and 5th metatarsal on Lisfranc injury. Be careful. They like to ask about the MTC joint fusion, most common complication, dorsiflexion, transfer metatarsalgia. You've got to know the position of preference for an MTP fusion. Radiographically, it's 20 degrees from longitudinal axis, the first metatarsal, longitudinal axis, the phalanx, and the lateral view, or to the plantar surface of the foot. The pulp of the hallux with the IP joint in neutral needs to be 10 degrees to the plane from the most prominent part of the forefoot pad and heel pad, and 10 to 15 degrees of valgus. Joint preparation and position. You can have they'll lead you along that path. You can have a fibrous union and a happy patient. You can't have a malunion that's solid with a happy patient. I don't know how much I ought to get into this, y'all, but if they ask you what's the most prominent part, this plantar medial bony prominence is there in a CVT. That's the head of the talus, by the way. And they love to tell you to get a dorsiflexion lateral x-ray. I know somebody that'll tell me to sit down. Y'all wouldn't tell me what time it was. But Dr. Miller's not shy. How much time do I have, Mark? I have 30 minutes? I'm going to wear them out then. I thought I was about through, y'all. I couldn't. All right. Sorry. Take a deep breath. If I get you out 5 minutes early, will you drink a beer with me? They want to leave now, Mark. Listen, in tarsal coalition, frequent sprains in the adolescent, the soccer player, and they keep tearing up their ankle and coming in, and mama's all upset because they know they're going to play for the University of Colorado. I heard there's a football team out here, but I'm not sure. Perineal spasm, less than a third of the patients. Ball and socket ankle joint, you've got to think of multiple coalitions. They love to ask this one. They've been asking it 30 years. failure of primitive mesenchyme to segment. Non-operative management initially. Calcaneonavicular bar, oblique X-ray, a TC bar, CT scan. They talk about resecting it if it involves less than 50% of the joint. Don't get me into that because it's vague, but nonetheless it'll show up in your test, not infrequently, go on and push that you resected if less than 50% of the joint involved. Nowadays, the pedipods are more and more influencing us, and I think the correct answer would be on your exam, and I haven't seen this one now, is they say excessive heel valgus associated with middle facet tarsal coalition. Excessive heel valgus. Then they want you to do, which means a little greater than 10 degrees, they want you to do a closing wedge sliding osteotomy at the calcaneus to correct some of that. Now, they might give you nothing but a weight-bearing lateral X-ray, and they'll tell you this patient has sinus tarsi pain and a tired foot and aching. And you get this X-ray and you see this dorsal beaking. Well, that's sort of, that sends your antenna up right there. But what they're looking for here is called a C, this ABC, C sign from a large middle facet tarsal coalition. They might not even give you a CT scan. That's all they give you. By the way, this is not an indication of severe enough DJD to preclude a medial facet resection. Are you with me now? Dorsal beaking of the talus is not a reason that precludes middle facet coalition resection. I threw this in here. It's a different plane on both feet. It's not really fair to do it. But what they're getting at is if this middle facet passes way over and it looks like more than 50% of the subtalar joint, because it overlaps at some, is involved, and then you can't do a resection. Now, excessive heel valgus you can't correct by an osteotomy, or degenerative changes in the subtalar joint, do a fusion. This is a subtalar fusion. One side might be symptomatic to go all the way to fusion. Another side might be asymptomatic. It's a strange entity. Now, what's vulnerable with the TC middle facet resection? FDL lies right over your incision that you want to take the bone away from. The posterior tib is immediately superior, and the FHL is just beneath the ledge of the sustentaculum. All of you know that, but remember, the FDL has to be pulled out of the way, the neurovascular bundle plantarward. In a CN bar resection, the most common injury is to the lateral branch of the deep perineal nerve. And when you get through, in the far depths of your wound, you see a ligament in the depths of the hole of your CN bar. You see a ligament in the base of it. What's that ligament? It's the most lateral aspect of your spring ligament, way over there in the hole. Kohler's disease, always treated non-operatively. And believe it or not, sometimes they'll throw out an ingrown toenail. Don't do a matrix resection in an adolescent. Do 2 or 3 plate resections, partial plate resections. Recurrent infections, okay. Still, don't do a matrix, germinal matrix resection in an adolescent. Now, these two they seem to love to throw out, and that is rigid club foot in the arthrorhipedic podic patient and in a patient with diastrophic dysplasia. Talipes equinovarus. They love that. Now, this is a worrisome one, so I threw it in because it's been in there. Leg pain with knee extended, pulse reduced or absent at ankle, and it's called the popliteal artery syndrome. Try to put that somewhere back there. Now, I've got a few minutes. I'm not going to talk about OCD because, Mark, aren't the athletic people going to talk about OCD of the talus? All right. Then just remember 2 things, and that's all. And if Dr. Miller tells you no, you believe him, not me. 2 things, and that's all. Lateral lesions are more commonly traumatic. Lateral lesions as a whole do better than medial lesions. and the most extensive data that we've got long-term still does not throw out drilling and curetting. I'm a little on shaky ground there. You've got to know the Sanders classification of calcaneal fractures. You've got to know Taylor neck fractures, the classification. You've got to know Hawkins sign. It's still around. I mean, Dr. Hawkins did us a great favor with that paper years ago. They like to ask about snow borders fracture. This is always an articular fracture. You can't fracture the lateral process of the talus without it being articular fracture. But if it's not big enough to fix, don't fix it. And they'll probably show you a CT scan so you can really get a feel for its size to know whether you've got to fix it or not. Always stabilize the lateral malleus before you fix the posterior malleolar fragment. They like to ask that question. Displaced articular fractures of the calcaneus require ORF unless medical or social history makes surgery too risky. Peripheral vascular disease, diabetes, neuropathy, and so forth and so on is listed there. Severely comminuted calcaneal fractures, yeah, this is where I don't know what to tell you. About half the questions will say subtalar arthrodesis. The others will say let it coalesce and do a late reconstruction. I just hope the wording carries you down the path that you want to go. That's the right path. Any displacement in a Taylor neck fracture requires fixation, greater than 2 millimeters. So that's not any, but greater than 2 millimeters. If a grade 1 or type 1 or stage 1 Taylor neck fracture, non-displaced, gets avascular necrosis of the body, they're probably going to lead you to a point where there was a spontaneous, marked subluxation of the subtalar joint and reduction, or the tibiotalar joint and reduction. In other words, you had more of an injury than you think you did. That's where they're going to lead you with the AVN after type 1 fracture of the neck of the talus. Hawkins sign is not sclerosis of the talar body. Hawkins sign, the radiolucency at 6 to 8 weeks on an AP X-ray of the dome of the talus, still a good sign of potential revascularization. One test had nothing but a 3-month after injury, fixation, fracture had healed, subtalar joint looked in good position, nothing but a weight-bearing lateral X-ray. And where they were leading you was AVN of the talar body was beginning to develop because you could see sclerosis of the body compared to the osteopenia of the distal tibia at the metaphyseal area there, subchondral area, because he hadn't weight beared on it in so long. Well, the talar body ought to be osteopenic too. Did I say that well enough where y'all can get a feel? You might have to diagnose AVN just from a lateral weight-bearing X-ray from the discrepancy in the metaphysis of the distal tibia. Subtalar dislocations, always get a CT scan. They'll want you to do that. You lose subtalar motion, usually not clinically significant. With a lateral dislocation, lateral subtalar dislocation, open dislocations of the subtalar joint are more common laterally than medially. But 85% of subtalar dislocations are medial. If you can't reduce a lateral subtalar dislocation, and some of them are tough. How many of you have had tough time reducing a lateral subtalar dislocation? It'll wear you out. Well, they're looking for the posterior tibial tendon interposed over the neck of the talus. That's what they're looking for. Medial dislocation irreducible. They might have peroneal tendons. They might have extensor digitorum brevis. They might have talar head fracture with interposition. But what they really want, and probably will give you as buttonhole through the extensor retinaculum. That's what they want. The talar head is buttonhole through the retinaculum. Now, we got an athlete. He plays for the University of Colorado. He's got vague midfoot pain, no swelling, good motion. Where they're leading you with all of that is to get a bone scan because the plain films are normal and they got a fracture of their navicular. That's where they're going with this. You treat that non-weight bearing for 6 to 8 weeks. If you get a non-union, you have to put a screw across it and bone graft it. That's what you want to answer. If they don't have bone graft and just screw, we'll pick it. But if they got bone graft and screw, you got to do it. If they don't heal in about 8 weeks. That's a sagittal plane injury. Midfoot pain, professional amenorrheic dancer, look hard for a stress fracture at the base of the second metatarsal. That's a favorite place because remember they're on point a lot. They might get a navicular stress fracture too, but both won't be listed. Lisfranc injuries, you've got to know the origin and insertion of the Lisfranc ligament. You just got to know it. Metatarsal fracture will always have a figure with it. The border digit, first and fifth, you can be a little more aggressive except in a ballerina. Central metatarsal fractures, leave alone unless there's 20 degrees angulation and you're afraid they're going to get a transfer metatarsalgia. Or if there's 100% translation with overriding in a bayonet position. If they look awful, fix them. But make sure they look awful before you recommend fixation for metatarsal fractures unless it's the first or the markedly displaced fifth and it's not a dancer. These turf toes are usually, they can be hyperextension or hyperflexion, but mostly hyperextension is what they're going for. Check the position of the sesamoids. Remember that proximal migration of the sesamoids that I gave you earlier? That's an intrinsic manus hallux built into it. That will take a $50,000 a game player and put him on the bench. So always check the sesamoids in a patient with swollen MTP joint following an athletic injury. Look for an osteochondral injury also. The stress fracture at the metaphyseal-diaphyseal junction. Now, you need to go to page figure 554 in Miller's textbook, page 354, and it'll give you the zones of fracture of a proximal fifth metatarsal: the avulsion, the Jones, and the dreaded black line, or a watershed of the vascular supply, distally and proximal. It'll give you all of that, and we won't bear on it here. Zone 3 fractures, though, that's the bad zone from loss of the nutrient artery. If there's sclerosis of the fracture site, obliteration of the canal, and conservative management fail, you fix them with a screw and a bone graft. If they don't offer you a bone graft, just screw, pick it, but hopefully they'll offer you bone graft and screw. Now, just a moment on this, and I hope the trauma guys cover it. Do you see this fracture line right here? This is your primary fracture line. This is the anterior edge of the posterior facet. This is the CC joint. The primary fracture line is in a posterior-medial direction, exiting the medial aspect of the tuberosity calcaneus, and that's what gives you that stable sustentacular fragment that you try to put the tuberosity to. This, the articular, the working end of this fracture that gets the patient in trouble and drives us crazy, is a secondary fracture line. Now, in Sanders classification, one fracture line, now this is a stage 2, by the way, 2 fracture fragments. Type 3 are 2 fracture lines and 3 fragments, and type 4 is comminuted. Type 2 and 3, Sanders classification, closed. There are some caveats and disclaimers, and maybe they'll put that in the questions. I don't know. But in the non-workman's compensation patient, non-systemically ill patient, you've got a 70 to 80% chance of a good to excellent result in a type 2 or 3 Sanders displaced articular fracture of the calcaneus. That's what they want you to circle, 70 to 80% chance of ORIF. Oh, on a lateral x-ray, they might give you on the single x-ray, what is the best prognostic indicator radiographically that this patient with an articular fracture of the calcaneus is going to do poorly. And what you circle is loss of Burler's angle, 25 to 40 degrees. It's down to 0. Loss of Burler's angle is the best prognostic indicator. I hope they don't get into the age thing because there's too much controversy about it. A fellow named Buckley that probably knows more about these fractures than anybody on earth thinks that age does make a difference, but Roy Sanders doesn't. So I'm not going to get into that. But age is usually, the older they get, you don't want to operate on them usually. Now, you got a big old swollen foot. What do I hit, Dr. Richardson? What button do I hit for compartment syndrome? Well, you do what your attending told you. If you think about it, son, do it. But for this test, you do multiple compartment pressure measurements over about a 30-minute period. You try to do 3 or 4 compartments, and it needs to be 40 millimeters of mercury or higher. And the reason you do them is you don't want ischemic necrosis of your intrinsics and claw toes, or you don't want permanent neuropraxia, neuralgia. That's why you do it, for the compartment syndrome. A distraction bone block arthrodesis, if they've got a loss of their talar declination angle on the lateral x-ray. Are you with me? Loss of the talar declination angle. In other words, the talus and calcaneus longitudinal axes are almost parallel, like a cavus foot. They're going to get anterior impingement. So if the talar declination angle is less than 20 degrees, put 20 degrees, less than 20 degrees, then they're going to have anterior impingement. You don't want to do a bone block distraction arthrodesis. Restore the normal talar declination and lateral talocalcaneal angle. This was a teenager that brought me his stirrup. Can you believe it? It's right out of an old French textbook, isn't it? Fix Lisfranc's, any kind of displacement, just 3 or 4 millimeters, fix it. I think they're fixing too many, but don't you circle that on the exam. You can get a ligamentous injury, probably requires an arthrodesis. In other words, you got a little flex sign, but no fractures at all. Well, go on and fix that, but that's more prone to give you the flat foot permanently if it's just a ligamentous injury. If you got some fractures associated with it, fractures bigger than just the flex sign, that's probably going to give you a good arch when you fix it. Either way, you might get degenerative changes at the respective joints. If you line up this one right here, the 4th and the 3rd, cuboid lateral cuneiform, on the oblique view is a good indication that you're, at least the lateral column is not involved, the central and lateral columns. Remember, it can propagate through the first the first intermetatarsal space, out between the cuneiforms, dart out between the navicular and cuneiform, and then you've got to fix cuneiforms and fix the cuneiforms to the navicular. Remove the screws at about 4 months. I would pick as long as you can. Keep them non-weight bearing for about 10 weeks, 12 weeks. I just don't have time to go through all that, so we'll. I think the other team will probably stress fractures, high index of suspension. We went over that a little bit, and how to treat it. The stress fracture from lateral column. Oh, on the orthoses, they might ask you about this. After a transmetatarsal amputation, I think you ought to pick toe filler over a carbon fiber foot plate or a steel rocker. That's what you ought to pick. And why? Because if you can get a full-length rigid plantar shank, you reduce the energy level that you're expending, and it increases your stride length. You don't come off the foot as quickly, and so your energy expenditure is less. So that's what they want you to do. But you've got to have a supple subtalar joint. And remember, you never can post more than 5 degrees of hand foot abnormality. It produces symptoms rather than help them. That's what they want, 5 degrees and no more. Your best orthoses are those P-like PPT things called cross-linked polyethylene foam orthosis. It's a blown foam, greatest shock absorbing properties. UCBL works by controlling hindfoot and a flexible deformity. The Sims prosthesis is unique because it has a suspension mechanism. It does not require an auxiliary suspension mechanism. Whenever you write a prescription for a rocker sole, you need to put a steel shank in it too. I don't know why they asked this, but they asked this twice. sick patient, 5 days after surgery, systemically ill, sick as a goat, and that's what they want you to think about. Now, the hand people usually put this in, but if it's frostbite of a foot, that's how you warm it up, 104 to 170 degrees. They got cold feet, blanched skin. A common foot condition that I suffer from markedly is foot and mouth disease. Y'all been very nice. I can't believe you sat there that long. Thank you.